We are now reconvening again as a plenary after having had some lunch and some discussions before the lunch. After the lunch, the leaders of the two breakouts were together with some help, trying to put together some slides to summarize what happened to the breakout sessions. Before we go into the discussion, I was kindly reminded to remind you that we do have an evaluation form, and it would be very much appreciated that you fill this in. And the second point I would like to remind you is that if we are here, it's for discussion. So it's not a discussion just between the distinguished people here and what happened before. It's also now. So please do not hesitate to make an intervention when you feel that you want to make an intervention. And we will go forward. Mario Opere, who is going to summarize what happened during breakout session 1?
Can we have the first slide? So we had, we'll just alternate. So we had a lively discussion, and one of the problems that came up was when you transfuse patients, there are several types of risks, or two types of risks. One is linked to the product, and the other one is the outcome in regards to the patient. And I think for the non-transfusionists among us, this was a clearly statement that puts things in order. And this is essentially our colleague from the US who said that first. And I would like Dr. Shanner to comment maybe on this, if you want.
Well, thank you. By the way, great job leading the group, both of you, because we're all over the place and you helped us concentrate. And I think that when we're talking about transfusion risks, we have to, again, divide it to the product, which is what the FDA in the United States addresses, is the immediate complications associated with the product itself being transfused, whether it be transmission of infectious or non-infectious complications. But ultimately, when we give blood to a patient, we want to measure outcome. So on one hand, we have the safety of the product, but on the other hand, we have the actual risk of transfusion, which is at that point tied to survival or morbidity of the patients. And I think that in the mind of clinician, we have to separate the two, because everyone talks to patients only about the risk of the product, but not in terms of outcome. And part of the problem is that we need to quantify that better and also have better studies to assess how we quantify outcome of transfusion in the patient population.
Thank you. So I think if there are questions or comments from the audience, don't hesitate.
Maybe we'll take them once we have gone through the summary of the breakout groups.
Okay.
So jot them down as you go.
So other aspects that were discussed in our group was differentiation between the different patients. You have patients who have chronic transfusion dependency, like MSD, or in dialysis patients. You have the surgical patients, and you have patients with chronic disease. So as regard MDS, Valeria made several points that maybe you can elaborate on.
Indeed. MDS patients are a group of patients requiring chronic transfusions. The length of their survival may be spanned over years. Therefore, the number of transfusions they will receive during their life is pretty high. This, of course, causes problems related to iron overload. Not only that, it impacts also a lot on quality of life and on concomitant problems, as we just mentioned previously in the general discussion. So the side effects of transfusion have to be realized well in this kind of patients, and the need and the threshold, the trigger for transfusion, which was commented not to be the right word to be used, but the trigger for transfusion is particularly important in this kind of patients, as they're facing years of transfusions, of course.
And what would be the trigger?
The trigger in our experience now has to be indicated by the patient. The symptoms of the patients should be driving the decision of the clinician together with the careful clinical evaluation of the patient and his/her comorbidities.
So the second aspect was on dialysis, and Kai-Uwe made a nice distinction between patients who are on dialysis, patients who will at some point in time get on dialysis, and I think we would be grateful if you could repeat your comments here.
Well, we know for patients on hemodialysis, we know from the times before e-protein was available that the majority of these patients do require blood transfusion from time to time, so they're transfusion dependent with the associated problems, in particular iron overload over time. And in patients not yet on dialysis, the problem is less significant. They also require transfusions to some extent, but not so regularly and not every patient. And so the current debate in the nephrology community tries to distinguish between these populations. And I guess there's some sort of consensus that in the hemodialysis population, we will definitely have to continue ESA use in order to avoid falling back into the situation where everybody is heavily transfused and has much lower hemoglobin levels. But in the population of patients not yet on dialysis, there's rethinking about the indication for ESAs, and as I outlined this morning, there's concern about the risk-benefit in this situation. And one important implication that one has to consider also is the risk of allosensitization in those patients who may, at a later stage, require a transplant or be able to receive a transplant. The data for transfusions leading to sensitization are not extremely solid, but what is available indicates that transfusions do increase the risk, and this is associated with adverse outcomes after transplantation and extended waiting time as well.
On the surgical patients, we had a lively discussion. Also, I had the impression that we were setting up a kind of hierarchy of physicians. Dr. van der Linden, I think you talked a little bit about this, and you also went into the second point on education, which seemed to be one of the major problems we discussed in our whole meeting. Could you comment maybe on the two sides?
Yes, thank you. For me, working in the university hospital, I think the problem is that most of the clinicians, at least in the surgical field, completely underestimate the risk of blood transfusion. They do not consider blood as a treatment. This is true for the anesthesiologists, but also for the surgeons. And the problem is that we have quite big difficulties to attract surgeons to participate to our discussion about when do we have to decide to transfuse, where do we plan to develop blood conservation strategies or modalities in order to avoid blood transfusions. For sure, there is a problem with the young generations, but also, as you told us during the discussion, it may also, and I remember a paper from Salem and so on, saying that all clinicians also are not always aware about the risk. So it's not only a problem of generation, it's a global problem of education.
Going back to the education was was a common theme during the whole session. It touched all areas. From the first slides of Dr. Hoffman in the morning, was clear that the way people treat to give transfusions vary. I'll pass it. I'll pass the microphone to you. So it's clear that you go from one institution to another institution is ridiculously the broad, use. Okay, so it means that somebody's not doing the right thing, or maybe there are protocols. So we can talk about that. Second, that I mentioned that really for the oncologists, one of the problems we have is that most of the information that comes with transfusions is really in non-oncology journals. So that information doesn't reach the oncologists. And when you go to a meeting and you suddenly, out of the blue, you loaded them, or you downloaded them, you know, with this information, so they don't know how to swallow. And if in the audience there's a surgeon or gynecologist, you have a very hostile person because there's a different also attitude from different receptors, okay, human receptors. So surgeons and gynecologists I find quite hostile against my talk sometimes. But it's clear cut that there's a need for more information, a need more for education among many of our colleagues, you know. Then somebody, I don't recall who, maybe you, about the need for a transfusion medicine as a specialty. I recall the NIH, like the Harvey Klein, the NIH was the first one to call in 85 or 84 Department of Transfusion Medicine. It was a big revolution then. They removed blood banking. It was the transfusion medicine. But I think that will never be a situation. I recall Dr. Maniatis, you want to make a comment on that? You say, will never be the time we would see a transfusion medicine because they're not, at least in Europe, where there's a concentration, reduction of specialties, probably there's not the environment to cause a new specialty. I'm right or wrong? You want to make a comment?
I stressed the point that there's a need for such a specialty.
Yeah.
But Dr. Zuccara actually mentioned that the European Union is limiting the number of specialties in the European Union. So it doesn't look promising that we will get. There is such a specialty in 6 or 7 European countries, but it's not throughout Europe. To my mind, transfusion medicine as a specialty would help in the issue of education of all clinicians.
Yeah. Who's doing now the role of transfusion medicine? Who's taking the role?
Nobody.
Okay.
In regard to the EU, Matti and also Dirk Schrijvers know from the ESMO side that there has been a battle going on now for many years to try to get medical oncology as a specialty, and it's still not clear. And the major reason why it's not a general specialty is because, as I mentioned before, there is a tendency to restrict the number of specialties because we as oncologists would like to have that as a specialty. The people who are interested in rhythm in cardiology, they would like to have a subspecialty and so on, and they're trying to restrict it. So I don't really see that there is in the very near future a subspecialty of transfusion medicine on the EU level. Now the different countries, obviously, they do what they want.
Would you like any comment? No? Okay. So, next, right? That's very interesting. Obviously, this issue was brought, also came out in the morning, and it's a quite important thing. The issue of the aging of the blood product, okay? The shelf life is 42 days, right? But we all know that with the days of storage, the quality of those red blood cells in terms of carrying oxygen decreases. And we've seen beautiful pictures on the morphology, changes in morphology, changes after the day 0, day 7, or day 15 or 20. And obviously those red blood cells after probably 2 weeks are not the same red blood cells as before. The question that you brought, right, is that there's not, obviously there's not a sharp, we try to get like a day, say, well, okay, after 15 days, we'll use the red blood cell transfusions for maybe for cardiac events, respiratory events, etc. And maybe after that, maybe for volume, maybe for hemorrhages. This will be a nice approach for the knowledge we know about the quality of red blood cells. But obviously, the decrease in the quality of the red blood cells is not a sharp thing. After day 15, it's not a cliff, and then the red blood cells become obsolete. So this slow slope, obviously, it makes it difficult to put a date which will be very beneficial to all the clinicians who take care of patients. So I don't know if you would like to give a talk on that, a comment, because you make a major talk on that. So
it's a physiopathological mechanism. That means that, of course, with the increasing storage, probably the ability of the red blood cells to deliver oxygen will be lower. but depending on the situation, is there really tissue hypoxia? You need to give oxygen. Are you in depth? Or we are just trying to supporting the compensatory mechanism of the organism. So it's very difficult. Moreover, I believe red blood cells have other properties, for example, as far as the coagulation process are concerned, and also this may be important to take into account when evaluating the age of the blood.
Fine. All right. Mario, want to say anything? I forgot. I apologize to Dr. Hoffman because I said you want to be a talk in the previous talk. So you don't mind, let's rewind a little bit. You've been given all these nice talks. Can your feeling of going back to the education, the big differences, you want to make a comment, how you visualize that, how you approach, how you try to change the things?
Well, we have this approach now in this Western Australian program because we can see the variability across countries, across states, across hospital systems, across departments, and in between physicians, right? So you can slice and dice it, and you see variability everywhere. And not only for red cells, but also the other components. So we analyzed for ourselves in Australia, number one, there is a tremendous lack of knowledge, so there is no sense of urgency. So we've got to implement a sense of urgency by an educational program covering these aspects you have discussed right now. Number two, you have to implement a continuous benchmarking system, an electronic system, which is feeding back on a monthly, on a quarterly, and an annual base to all departments and all physicians. And we know now which physician in what department is responsible for how many transfusions at what time from how many patients. And I think somebody said you don't want to be the last one on the list when you see these reportings. And I think I can report more about the scrutiny of quality of physicians in the United States. This becomes an indicator of the quality of the medical and surgical service of an institution, how much or how little blood is transfused. So it's education and information feedback with an electronic benchmark system.
Okay. I think yeah, please.
This is a very important point, but I think I like the idea that you have a list and that you can break it down to more or less a single person. But if the bleeding and all the problems have been caused elsewhere, and the anesthetist is the person who's at the end transfusing everything, you're more or less tracking down the wrong person.
Yeah. Should I respond to that directly, or?
No.
No.
Yeah. You want to answer?
Can I?
Yeah. Somebody.
Of course, this reporting system we have implemented now is not by itself. There is not transfusion nurses, but we call them now patient blood management nurses, and their job is to go to those outliers and say, okay, let's discuss what did you do in terms of the first, second, third pillar. Did you miss out on anything? Why is it that your patients are bleeding more? What about stopping coagulation inhibitors and things like this? So it is really, information is the first thing, but then there is this interaction between the transfusion, the PBM nurses and the physician.
That costs money.
Yeah, but it saves much more than it costs. No, it pays back immediately. The return of investment is a wonderful immediate return of investment, and I think you can see this rarely in other fields of medicine.
Okay. I would like to see the point of view of the Scandinavian countries, because it came out in the discussion that you have different threshold. Can you explain it to us?
I think it's an important point that lack of blood or not lack of blood plays a role here as well. I mean, in Scandinavia, typically we don't have a lack of blood for the patient, so we could, and we tend to have a higher trigger HB level for transfusions. When I started medicine, it was 8, and then stepwise, now it's 9, sometimes even 9.5. Sort of acknowledging that quality of life is an important aspect, even with transfusion, not only with erythropoietic agents.
So you're not too concerned on the side effects or the risks that we've been mentioning the whole day?
Yes, of course there is a concern, but there are other concerns as well if you have chronic cancer disease.
Okay.
And
seems
quality of life, I think, is an important
no,
piece in
for
this
me too.
situation.
Yeah. All right. So, any further discussion of that? So we'll go now to the. We have still more to go. The reporting of adverse events and complications. We brought the issue that how much we report that, and apparently this was almost a common theme. It's easy to report acute events. In fact, there are protocols, at least in Spain and in Europe. I'm sure we have a blood bank like form. There's any acute event, the people from the blood bank come, evaluate, and they do the whole thing. But obviously, what happened about the long-term like complications? You mentioned the allogenation, you know, with a nephrologist, a blood transfusion, etc. You know, so it's a problem. Do we report? Maybe the audience can answer that. Do we report really accurately the long-term side effects of the transfusions? Do you have any comment in the audience? Or we just do the acute events? In other words, how we document the side effects, if any, of the blood transfusions out of the acute ones, which is the easy part? Yeah, you go ahead.
I believe that apart from the acute adverse consequences, which are immediately recognized as being associated with the transfusion, there's a tremendous problem, and we also discussed this in the group, and that is confounding by indication. And I don't think that any sort of approach can actually tell us a lot about adverse consequences unless we do prospective randomized controlled trials. And when I hear from my colleague on the right that in Scandinavia, the transfusion trigger for patients with chronic anemia has increased over years, I find this very interesting. But I think we would need RCTs to demonstrate whether there's a difference in outcomes between a trigger of around 8 or 11 in patients with chronic anemia. The tools are available for that. We have seen a couple of very good studies in the intensive care setting. The results of these studies have clearly influenced on how we manage our patients today. And I do believe we need similar studies also in the area of chronic anemias.
No answer?
No further comment on that?
There is a study that was completed, an NIH study looking at a large cohort of orthopedic patients with hip fractures and transfusion at 8 versus 10 grams per deciliter, showing no difference. So again, going back to the TRIC trial and the pediatric critical care, all show no difference. So a conservative approach certainly has the advantage of reduction in cost, the potential reduction in complications, although those were not well described in these trials. That was not their indication, if you will, as well as providing the same level of care by conserving a significant amount of resources. So again, conservative approach makes the transfusion more of a difficult clinical decision rather than a trigger.
Take a look at Telly.
Yes, but I think that the discussion we had this morning about the TRIC trial, I think we should, the way we are interpreting the data is of paramount importance, because of course it's important to have the randomization to the patient to less than 9. But if the patient during the trial forward didn't reach the level, they stay to 10.6 as a median value, you can say that 9, less than 9 is safe. Otherwise, we have to have a longer follow-up in order to allow the patient to reach 9 before giving this kind of conclusion. What we can say is there is no data between 10.6 and 9. So we need this data, but the data are not available.
Well, no, go ahead. Oh. Yeah.
Okay. We do have some interesting data in cardiac surgery on long term, thanks to the work of the Cleveland Clinic. And they have this huge clinic doing systematic follow-up, and they presented on the Annals of Thoracic Surgery some 16,000 CABGs procedures, showing that transfusion is definitely a determinant of mortality. So this is where the attention in the cardiac surgery world started against the surgery. So we do have this sort of data. Of course, it's retrospective data. We do not have randomized, but it's a starting point.
Yeah, go ahead. Yeah.
And in addition, I mean, all the studies come to the same conclusion. I mean, particularly cardiac surgery is so well investigated, mainly with retrospective studies, but with propensities matching and match pairs, and whatever you want. And there are many papers that used different statistical models to compare the outcome of transfused and non-transfused patients, and all come to the same conclusion, that mortality is increased, infection is increased, renal injury, lung injury, pulmonary complications, everything is, and those dependently negatively affected by each transfusion, each unit you transfuse. In addition, just in October issue 13 of the JAMA, there is this prospective randomized trial in cardiac surgery performed in Brazil on 500 patients when comparing hemoglobin or hematocrit transfusion trigger of 24 versus 30. And these two groups were completely comparable to start with. The outcome was zero difference. So that means, transfusing more does not improve your outcome at all. And then, we discussed several times about, a drug being introduced for efficacy, and safety and lack of side effects is another aspect. But first of all, something is introduced for efficacy, and efficacy has never been shown for blood transfusion without, except for very, very niche indications where there are studies. But if we would transfuse just in these cases, we would transfuse like 10% of what we transfuse today in the perioperative setting. So I don't see that, just calling for yet another study would really resolve the problem, because the sum of all what this has been described is so huge that why don't we, kind of do something that avoids transfusion, because we know that it is adversely affecting outcome.
Education. Wait a second, the Shrivers, and then you.
So we also see that in oncology, that when you give transfusion, there may be harm on long-term outcome response rate, but also in survival. The problems with these studies is these are small retrospective studies, and you have a lot of confounders that you don't take into account. So it's very difficult to say something about the relation between transfusion and the long-term outcome. I agree that it will be very difficult to do some randomized controlled trials in these settings and to evaluate long-term complications or outcome. And that's why I also think it's important that we see blood transfusions as a drug that you have to use sensible, safely, and limited use to real indications where it's needed. And for instance, in oncology, the cutoffs are not so a big issue. We mainly look at the quality of life. If a patient has complaints, this is a reason why we are transfusing. And also because we know there is some impact of anemia on the treatment outcome with certain treatment modality like chemoradiation. That may also be one issue to consider when giving a transfusion.
Professor van der Linden, yes.
I just want to come back to the study mentioned by Donat Spahn. It was also interesting in the Brazilian study is that although there was no difference between the restrictive and the liberal transfusion group as far as outcome is concerned, the authors also emphasized the fact that whatever the group, if the patients have been transfused, the outcome will be better if they will not be transfused, whatever the group they belong to. And this is what I wonder. It may be interesting, but I don't have the answer, perhaps you have, is to try to differentiate the effect of transfusion according to the indication. Do you give a blood transfusion to maintain a certain hemoglobin concentration? For example, in cardiac surgery, you have to maintain 24% hematocrit, so you will give blood just to maintain 24% hematocrit? Or are you giving blood because the patient is bleeding a lot, or because you believe he needs more oxygen to be delivered to the tissues? And perhaps the indication may influence the outcome associated with blood transfusion.
Yeah. You want to talk, or Dr. Hoffman?
I just wanted to disagree to some extent, perhaps, if there's a notion that we don't need the trials or that we can't do the trials. I think if we see that there's such a heterogeneity in clinical practice in this area, and the data actually allow us to do a trial because they are by no means supporting that transfusions are needed. You know, all these ethical concerns when studies are being planned about issues that are well established in clinical practice, the first thing that comes up is that people say, well, what about the ethics? Can we withhold transfusions? And what you're actually saying and quoting, I think, opens the door. And I believe that we cannot predict the outcome. We cannot predict the effect of quality of life. This may well be a huge placebo effect with adverse consequences for certain patient groups. I'm not saying that transfusion trigger a specific hemoglobin target may be sophisticated enough, but in the chronic setting, I think if it turns out that we will see less use of ESAs because of safety concerns, transfusion, the discussion about the safety and benefit of transfusions will be revitalized, and I believe that we need more studies to actually support what we are doing.
Dr. Hoffman, you want to answer this question right away?
No, I'll talk a little bit about that, but just the issue of the TRIC trial, and I think that Professor Locatelli is right in terms of how you have to look at the endpoints of these studies and whether patients actually reach endpoints. So on the TRIC trial, you're correct when you're looking at the analysis, but let's see what's happened since the TRIC trial to today in terms of transfusion and the trigger, if you will, or the level of hemoglobin in intensive care unit is continuously dropping because of that, and without any increase in adverse events. So I think that although you're right about the trial, the effect of the trial still resonates. The other issue that we already passed, but just to think about this, one of the problems we're constantly thinking is in terms of the value of transfusion and whether it's there or not. In fact, we need to think about why patients come to the point of transfusion. And I think we mentioned that usually a transfusion, in my mind today, is a missed opportunity to do other things. And I think we can't forget that patients come in and end up being transfused because no one is thinking about the other opportunities. And we need to think about that because we're all talking about the same thing, which is the risk of blood and the risk of transfusion. So there may not be transfusion specialty in Europe, and I could tell you that even in the United States, there's very small numbers where you can get them. But there is one other activity which may bypass that, and that is a transfusion safety officer. Because again, we're concerned with the risks, really no demonstration of benefit so far. So why not have someone who is an educator, transfusion safety officer in a hospital? And that's what we're resorting to in a lot of places because as Axel Hoffman was saying before, we now measure performance of clinicians. And one of the way we measure performance is with transfusion because it is a measurable outcome, if you will. And it's undesirable outcome only because we're missing the opportunity, as I mentioned before. So there may be other ways of looking at it.
One second. Yeah, we have to keep running.
Coming back
and
to
then
the randomized control trials. First of all, I don't want to be in a control group, and I think everybody would understand. Yes, and of course it is kind of the standard, and for the regulators, we need level 1 evidence. We need randomized control trials. Why do you need them? Because you need the statistical tool when there's uncertainty, and I clearly understand that. But it's always portrayed like, you know, observational study is no evidence. It's at least level 3 evidence. It's good evidence, and I want to relate and discuss it with some colleagues today to the history of lung cancer and tobacco smoking. There was never, ever a randomized controlled trial. We didn't randomize 16-year-old kids into smokers and non-smokers and then check the results. Right, but the father of the randomized control trial, Sir Austin Bradford Hill, who was also, I think, was the president of the British Statistical Society, together with his colleague Alfred Dahl, they developed that concept of the Bradford Hill criteria to establish causality from correlation. And 2 of these 9 Bradford Hill criteria are a dose-dependent signal, and this is really very interesting that across several 100,000 patients, across 25 different patient population, we can clearly see an incremental increase of the adverse outcome with every additional unit transfused. So there's a very strong signal. This is a clear pattern across a few hundred studies, I think, Donald, right? And the other one is a mechanistic model, which addresses the physiology part of things. And there is a lot of basic research out there, research 30, 20, 10 years old. If you pull that all together and look into the biologics and the biochemistry and the rheology and the mechanics and whatnot, then you find so many reasons why transfusion doesn't do the job we think it does. And we should not continue to ignore this, but put this into the greater picture and think about whether could we apply the Bradford Hill criteria as we did it in asbestos and cancer and smoking and cancer. Why don't we have a look at it in transfusion and adverse outcome?
Short.
Going back to the treat trial, I think that it's completely different to the indication for the acute transfusion because the patient had 7, something like that. So I think there are no problem to wait till 9, for example, for the acute phase. But in the chronic phase, you have to take into consideration the quality of life of the patient. And even in all the trial, there is a clear trend favoring the higher hemoglobin level. So I'm absolutely against to normalize the hemoglobin level because this is for sure is a great mistake because you are increasing the danger for the patients. But considering that even in the treat trial, with this double blind, there is a there is an advantage in the quality of life of the patient. You can imagine reducing the hemoglobin level to 9 in the long term. So I think the patient point of view should be taken into consideration carefully for the chronic kidney disease. Because the patient sent a letter to American Journal of Kidney Disease clearly underlined that there are very important hard outcomes, but also the quality of life of the patient should be taken into consideration. I think for the chronic kidney disease, without giving any risk to the patient, but we have to take into consideration the quality of life.
Okay. We are running out group 1 out of the quarter, so we just discussed most of the issues. Let me just read these 4 things and I'll pass the baton to Matti. It's clear that there are different awareness among different collectives of physicians in the use of SS. We just find out that in the United States, surgery only is 0.5%. And then also for Dr. Maniatis, we find out that there has been a decrease in Europe, right, of 31% of the use in SS in oncology, and at the same time an increase in transfusions rate. The other interesting thing, the autologous transfusion now almost abandoned for multiple reasons, but one major issue was logistics. Okay. The third thing is that change in use in SS in oncology and nephrology is clear, especially in oncology. We're all aware. One of the reasons we're here is because the big problems, big clouds on SS. And then we discuss obviously the SS transfusion IV iron, but there's no time for discussion. So I think, let me see. Well, we finish this as a provocative thing. Anemia is bad, right? Transfusion sometimes necessary, but it's still bad, right? And what are the alternatives? SS or IV iron. So I don't think we have more time. So Matti, you want to have it? Yeah, you have.
Okay, group 1 discussed, group 2 discussed, and in many areas you'll see that we come to very similar comments, and we also had some slightly different tasks. And the first question that we tackled, what are the implications, the recent data on blood transfusions in clinical practice in your specialty? And as previously mentioned by Group 1, we also realized that there is a clear lack of awareness of any guidelines, and that this is one of the issues in many centers. We also commented on what was commented earlier this morning and also by Group 1 about the differences in use of transfusions in different centers. And we felt that even though many of the data were discussing about the surgeons, that this is not really a surgical issue, it's a clinical team behavior issue. And then we tried to answer what can be done, what could be done to improve, and several of the Group 2 participants indicated that one of the ways to go is to conduct in your own center an audit and look at what is going on. Because one of the points that had been made is that while some might recognize that there are guidelines, they will say, that's fine, but it's not me. It doesn't concern me because I'm perfect, and it's the other one. And then it's only when you start measuring what is really happening that you realize that maybe it's not always that's true, and that something needs to be done. Also, in order to improve in the setting of course, operations that are elective, we're not speaking of emergency operations, but of elective operations, we've had some discussion about the fact that it's difficult in some clinical settings in some countries to organize in such a way that the patients are seen early enough by the team so that they arrive to the operation with an optimal hemoglobin, depending on what is the reason why they have anemia. So, because we have all those data that show that transfusion depends very much on the initial hemoglobin level. So we discussed that it would be important to really implement pre-surgical consultations weeks before. Because elective surgery in most countries today, it's 2, 3, 4, 5, 6 months delay until finally the hip operation is done, the knee operation, or God knows what. So there's plenty of time to correct issues if you think of them in time. Of course, if you think of them the day before surgery, it's a little bit late. And then it leads to, even the best hands of the best surgeons, to enough blood loss. And also, we emphasize in our discussion that it's not only during the surgery. Today, after surgery in the intensive care units, and certainly in oncology, we tend to draw blood for lots of good reasons and lots of bad reasons. And when the blood is drawn, there's a huge amount of blood drawn. And I think, Axel, you were the one commenting that basically the amount of blood drawn in some of these units on a daily basis is much more than can be physiologically replaced. So it's no surprise that after a week in a hospital, patients leave being anemic just because there was blood drawn to do repeated tests 3 times a day. So it's not a surgical problem, it's a multidisciplinary challenge in order to reduce transfusions and, of course, use transfusions when needed. And we felt that we needed more discussion in the setting of the chronic use of transfusions in nephrology and MDS, but MDS has been now very nicely discussed by Valerie a couple of times, so we didn't discuss that, and we had some other comments about nephrology. So I'll leave now the comments to Axel for the next slide. Oops, sorry, let's go back. There we go.
Yeah, then we said there are a few other issues about the cost of blood. What you've seen this morning is what is the cost of outcome, what is the cost of administering the blood, but there's of course also cost incurred to the donor, and donors give their free time. They use the taxi or the bicycle or car, whatever. We can measure this in terms of opportunity cost. There's also a large fraction of donors which donates during work hours, so there's also a factor of lost productivity. And then, what was the other point? Oncology patients have, and then in the oncology setting, especially with CIA, patients, they come to the institution exclusively to receive their transfusion. So there's an additional overhead cost because the whole facility is used for this very purpose, transfusing the patient. So that if we did a cost analysis on this, we would even expect higher costs than we had in our study on the surgical patients. In a nutshell. Next one.
Yeah.
And yeah, this is an interesting comparison we discussed. Some heard it already. When you click on the website of the regulators in the developed world, FDA, EMA, and then within the European Union, BfArM and Argus and whoever they are, MHRA, I think, in the UK. And you read their mission statements and their goals and aims, then you find, when it comes to medicine, number one is quality. A product has to be produced with good manufacturing practice, GMP. The second one is safety. And we all understand that quality and safety is not the reason that we produce medicines. This is just a necessary condition that we can bring this drug to the market. But the sufficient condition is that the drug is efficacious or effective. So quality, safety, effectiveness. If you look into how these regulatory agencies handle blood and blood components, interestingly, they only focus on quality and safety, and there is no mentioning about efficacy. So we really treat transfusion or blood components as a totally different animal, and at the same time we are spending billions of dollars on this kind of a treatment. And I think in times where healthcare reforms are on everybody's agenda, we cannot afford to continue like this. We have to draw the attention of the regulators to this very issue and let them know here is something which grandfathered into the system 60 years ago, transfusion practice, has rarely been reflected on, and there's a need for reassessment. I think the other issues.
I'll take the other points then. As Group 1 did, we discussed these important data that not everyone realizes how important they are about the quality of the blood. One of the issues that is not really looked by the regulators. Can we continue to use blood which has been accepted as being quote-unquote good, which is 42 days old, when we realize what it really is? And in which settings? Should we have different indications for blood which is relatively fresh compared to blood which is relatively old? All topics which need adequate studies in order to have the correct answers. Looking at the perspective of efficacy, Paul Kohns attracted our attention to the fact that within the oncology field, there's one and only one study on blood transfusions showing that there's quality of life improvement, and that is in the setting of lung cancer patients. And that nevertheless, transfusions are used in supportive situations, sometimes in very important supportive situations, in order to allow a patient to go through a treatment which induces very important anemia. But we have also questions about the safety when patients are transfused, and we have no idea of the long-term data there. And therefore, we should recognize, and Axel already said, that yes, well, transfusions have come, they are there, but our regulators right in saying we are certain that they are safe in the long term, but they might be very safe in the short term. But even there, we are neglecting some of the acute reactions which happen. And everyone who transfuses knows that we do have those reactions which tend to be underreported. And actually, this comes to a point that Hartmut alluded to in recent discussions in Germany, where some regulators were sitting in the room. The regulators were looking at him and saying, well, we don't believe all those data that show that there are issues in the short term, long term, medium term with transfusion, all these settings. These cannot be true. We know that transfusions are safe. So this is quite kind of a strange answer from people who should look at the data and say, well, there is a question. If non-statistically significant differences in hematological oncology or solid tumor oncology lead them to put all black box warnings, they should also look at other warnings telling that there may be a question and maybe we should address those questions in an adequate way, and those studies should be funded. So to come back to the MDS situation and looking at the use of transfusion ESAs, we discussed very briefly in our group that one of the reasons why ESAs are not used in spite of the scientific evidence that was so nicely discussed earlier by many is that they are not licensed. It's not a licensed indication. So in some countries, it's just not possible to use ESAs. So therefore, you use transfusions. And maybe I'll allow now my dear friend Francesco to say a few words. No, I'll keep this. Say a few words about TREAT and the fact that there was a meeting by the advisory committee at the FDA, the cardiac, on the results of TREAT, and would they or would they not affect the indications for ESAs, at least in North America?
I think that the major question were related to the use of ESA in patients not on dialysis. It is important to recognize that out of 15 experts, 44 were in favor of continuing the treatment of the patient not in dialysis with ESA. And this is the major point. Of course, there are many other aspects. There was a discussion related to which is the target and so on. But in general, what is the major reason is there are no reason for stopping the ESA treatment in patients not on dialysis. I think that in reality, there are not too many differences between the patient in dialysis and not on dialysis. In my view, the problem of the patient not on dialysis should be in some way even better for treating this patient, because in dialysis we have the fluctuation related to dialysis. So there is a sort of diluting effect of dialysis. So the hemoglobin levels are not the same. In hemodialysis, the same hemoglobin level probably will indicate even more hemoglobin level. So I wonder why there is so much discussion in the difference between dialysis and non-dialysis, when the problem is which is the target that is safe for the patients without, of course, jeopardizing the results. I think this is the major issue. Because, for example, if I decide to treat my patient earlier, so the hemoglobin level are 11, I can use, in this case, the ESA, or if decide to maintain the patient not on dialysis and to start dialysis later, there are no reason for starting ESA because the patient didn't start dialysis. So I think this is the problem too. There are many points of discussion, of course, so I think we have to better clarify these aspects.
Are there any comments from our colleagues nephrologists about this particular point before we move ahead?
Despite all this, the number of patients who are being treated with ESA prior to dialysis is still pretty low.
Yes, but this is true, because there is for sure there is an inertia, because when there is a long queue outside your outpatient clinics, you have to make a special arrangement for allow the patient to use the ESA. Okay, we say, maybe my colleague later on will do it. Right. So I think that this is the problem. I don't think there are any other reason for discussing that. Sure, one of the major, let me say, message for the TREAT trial was to underline that before treating the patient with ESA, we should give the patient ESA. It was very clear also in the guideline from the beginning. But of course, reinforcing the message was very, very important indeed, because even in the TREAT trial, you can see the criterion for treating the patient with ESA was 15 of saturation, transferrin saturation, that is low. So even in the trial. So I think that is important for remember that before treating the patient with ESA, you should look at the saturation, the score of the iron score in order to be sure there are not iron deficiency. The other problem is to be careful about the secondary analysis because the p-value kill already so many patients that we should be very careful. Yes, this is true. Because everybody are discussing about the hypothesis generating, that is important, about the strokes, but of course is a matter of concern, but it's not a demonstration. The other side around, if you look at the treat trial, there is a message that increasing the hemoglobin level, you are reducing the risk of cardiac revascularization. Nobody are discussing of that, but because I fully agree, because could be a statistical fluctuation related to the fact that the number of the patients are very small. So I think that in general, the message is consistent in saying you don't have to increase too much the hemoglobin level. Maybe 11 is enough, but be careful in decreasing too much. Before decreasing the hemoglobin level to 9, for example, according to the experience of the treat, we need a randomized trial. And the position statement of the KDIGO before the publication of the treat trial was that the range should be between 9.5 and 12. So it was before the treat trial. So I think there is, giving a larger range than before in order, because the patient is not symptomatic, there are no problem, no any complication. I think that maybe 9.5 is fine. But in case there are problems, you can increase the hemoglobin level of the patient for improving the quality of life without using the drug off label. Increase the range probably.
Okay, well, thank you very much, Francesco, for these comments. And the next point that we discussed was indeed that in this whole field, in spite of, for example, in oncology, us having finally found out what the nephrologists have found out a long time ago, that if you add IV iron, you improve on response rates. You still have patients that are not responding. Who are these patients? How can you predict in advance who is going really to benefit in terms of quality of life, for example? And all of this means that other studies are needed, and we were told that at least in nephrology, new studies are ongoing. Then we hit the question of IV iron that I just mentioned to you, in the sense that the question we were asked was, how are transfusions used for non-responders to iron and ESA treatment? So the first thing that we ask ourselves is, what is the evidence we have out there that IV iron is indeed better than oral iron? And in the nephrology field, this seems to be very clear. It's related to the GFR. When there is a need for dialysis, there's no discussion. IV iron is clearly superior to oral iron. But there seems to be still some debate in the field of nephrology whether the patients before they're in the transfusion stage always need IV compared to oral iron. One of the issues with oral iron is, of course, compliance. For many of these patients, not that easy. If you have ever tried to eat some of those iron tablets, you know what I'm talking about. And then we discussed the fact that in oncology, patients in the adjuvant setting, i.e. patients have no cancer, we are just giving them something that we believe will delay or will allow them not to ever have cancer again, and making them sick because of that, and then putting them in a situation where they might need iron. We have no proof that in that setting, for these women or men, there is a need for IV iron compared to oral iron. All the data we have are in more advanced cancer settings. And the answer was that if patients do not respond to adequate iron plus ESA treatment, transfusion should be used as a last resort and not, as we have been suggested by authorities, as the first resort before we think of iron and ESA use within the guidelines that have been put forward. Axel.
Yeah, should it be linked to quality of life? The question then is, I mean, how do we really measure quality of life, especially when we see that we have fluctuating hemoglobin levels with transfusion versus a sustained improvement when you stimulate the erythropoiesis? Because then you create new red cells with 120 days lifespan. With transfusion, you transfuse a product which is already half dead, and you have these drops now. If you have a continuous measuring of the quality of life across I don't believe that this is that the study is of that quality. Probably, Dirk, you have a comment on that, because you were. When is quality of life measured in those studies? At what point of time is the quality of life measured? Right after the transfusion, during the, across the whole transfusion, the whole time after transfusion, or just in one point in time?
No, normally in quality of life studies, they are measured throughout a time span. But in the IV iron studies, they were measured just before the next consultation. So it's very difficult to see what is the real impact of quality of life, because it's also decreasing when you are giving transfusion. When you ask patients, did you feel the effect of the transfusion? Most of the patients says, yes, we felt something, but that's not it's a subjective feeling. Yeah. And it's at a certain time point. So
yeah, the background for this was we felt that there is a large amount of uncertainty. Yeah. if it really works, and if it's a real benefit.
But in MDS it is.
If I may comment briefly on this. We also had several studies on quality of life in MDS. There are two levels. Right. One is the fact that patients do feel better after transfusion, so symptoms are lessened. But there is the other very strong feeling of dependency from the hospital, which is, of course, decreasing quality of life. Yep. So there are two different, the physical wellness is increasing, so the physical quality of life is better. The social quality of life is much worse. So I think you have to do a very different evaluation of the two scoring systems.
Yeah, which underlines
it's very important, I think, to understand the difference between symptomatology relief and quality of life, which are very different, as you just mentioned. But when you interview patients on quality of life, the quality of life on ESA is reported to be across the board higher, because they don't have to stop to go to they can sometimes inject themselves, but they don't have to stop and get the whole issue of the hours of transfusion. Yes. Versus a few seconds of injection. Yeah. And that's across the board. The problem is that this is a qualitative versus a quantitative measure. We've quantitated quality of life, but still, it's still a qualitative measure, if you will. And translating into numbers is why at least on the FDA side, they're not readily accepting quality of life as a measure. But in fact, any patient you interview has clear distinction between the quality of life and symptomatology.
Let's move forward.
Forward?
I think it's the last one.
I think it's the last, yeah.
Indeed. We were just coming with Axel. So this was the end of our task.
Marty, can I just, because you guys, I'm sorry, just a quick comment. We're all talked about iron, the difference between IV and PO iron, and looking at iron as an adjunct therapy. One of the things that I think we need to address and not leave the room is the adjunct therapy to iron, which is ascorbic acid, and the influence of ascorbic acid, both for IV as well as for PO iron, in terms of transport as well as absorption.
Yes, but the risk of oxalosis to be taken into consideration, because at least for our patient is a very great risk.
I'm talking about the oncology patient. I think that yes.
And also avoiding IV iron in patients not on dialysis is important for preserving the veins, but maybe could be useful later on for vascular abscess for dialysis.
In the first version of the URTC guidelines on the use of ESAs, we had a mention about vitamin C. This was not then taken up later, because unfortunately we lack appropriate studies in the setting of our patients to give any guidance about this observation and others, about other potential factors that could improve also the response rate. So you're raising a point for which we need studies, but we agree that there is some evidence that might be sometimes useful, but we just don't know exactly for whom. So I was saying the task of the group 2 stopped there. Group 1 has reported, and before we decide that we are ready to have a break, and prepare for the internet transmission. We still have a couple of minutes if there are any further questions, comments. Yes, please, Ian McDowell.
Maria, I just wanted to pick you up on one of the comments in your slides about IV iron being superior to oral iron in dialysis patients. I just want to be clear what we mean by that. So in terms of the surrogate endpoint of hemoglobin and reducing ESA dose, there's no question that IV iron is superior. What we do not know is that we're flooding our dialysis patients with intravenous iron over many years. Is that safe? And we do not know the answer to that because there are absolutely no randomized controlled trials to support it. So I just wanted to be clear what you meant by that comment.
It's a good point you're making there, and we made it earlier this morning in the presentations that while we have these data that show that the use of intravenous iron increased response to ESAs, we still have several questions open, and one of them is long-term safety, for which we have no answer. You're absolutely right. Okay, so well then, thank you very much, everyone, the faculty and you all.